My name is Courtney Womack, and this PowerPoint will discuss tubular maximum and renal threshold in regard to glucose. What is tubular maximum? So, tubular maximum is the maximum reabsorption rate. Is designated as tubular maximum, or TM. Any quantity of substance filtered beyond its TM is not reabsorbed and escapes into the urine instead. With an exception of sodium, all actively reabsorbed substances have TM. The reason why sodium is excluded is because sodium is actively pumped out, while potassium and chloride diffuse down their electrical chemical gradients through channels in the tubule wall and into the bloodstream. The walls of the thick ascending limbs are impermeable to water, so in this section of the nephron, water is not absorbed along with sodium. And even though individual sodium transport carriers can be saturated, the tubules as a whole do not display a TM for sodium because aldosterone promotes the insertion of more active sodium and potassium carriers in the distal and collecting tubule cells as needed. So the transport maximum, TM, the maximum rate of a substance carrier mediated transport across the membrane when the carrier is saturated. This is known as tubular maximum, as I mentioned before, and the transepithelial transport across the kidney tubules. What's a renal threshold? A renal threshold, the plasma concentration at which the TM of a particular substance is reached and the substance first starts appearing in the urine, is known as the renal threshold. At the average TM, tubular maximum, of 375 milligrams per minute and GFR of 125 milliliters per minute, the renal threshold for glucose is 300 milligrams per milliliter. Beyond TM, reabsorption stays at a constant maximum rate, and any further increase in the filter load leads to a directly proportional increase in the amount of the substance excreted. What's a renal threshold continuum? So this was an example provided. So one example is the plasma concentration being 400 milligrams per 100 milliliters, with a load of glucose filtered is 500 milligrams per minute and 375 milligrams per minute, which is reabsorbed, and that's the full with the TM value, and 125 milligrams per minute is disposed in the urine. And the plasma glucose concentration of 500 milligrams per 100 milliliters, and the filtered load is 625 milligrams per milliliter. Still only 375 milligrams per minute can be reabsorbed, and 250 milligrams per minute will be disposed and will spill into the urine. So a normal plasma glucose concentration is 100 milligrams per 100 ml. So when the plasma glucose concentrations are high, such as the one in this example provided, it will cause health problems. So disorders associated with high TM. So as mentioned in the previous slide, when glucose concentrations are too high, it can cause serious health problems such as diabetes or diabetes mellitus. Is an endocrine disease that is caused by a deficient insulin action. Insulin is a pancreatic hormone that facilitates transport of glucose into many blood cells. And diabetes can be detected by using a urine sample. A doctor will do a strip into the urine, which can change colors according to the levels of various substances in the urine. And the doctor will usually compare the strip with the color chart to determine the level of glucose, ketones, and proteins in the urine. And abnormal levels of ketones is when the cells don't get enough glucose, so the body will start to burn fat for energy instead. And this causes the ketones to produce. And this usually shows up in the blood or urine. So high ketones level in the blood indicates diabetic ketoacidosis, known as DKA, and a complication of diabetes, and this can lead to a more serious problem, such as a coma, or it can be fatal. Disorders associated with high tubular maximum TM continue. So when cellular uptake is impaired, glucose that cannot gain entry into the cell stay in the plasma, which causes an elevation in the plasma glucose. Consequently, although glucose does not normally appear in urine, it is found in the urine of people with untreated diabetes. When the plasma glucose concentration exceeds the renal threshold, this will occur. And even though the renal function hasn't changed, so the renal function won't change when the plasma concentration exceeds the renal threshold. So this is the scholarly article that will be discussed. So this scholarly article is renal handling of glucose as a function of plasma glucose concentration. Oh, I'm sorry, this is not the scholarly article, this is just the graph that I have. So you can see it's a renal threshold on the x-axis and the tubular maximum on the y-axis. So at a constant GFR, the quantity of glucose is filtered per minute is directly proportional to the plasma concentration of glucose. All the filtered glucose can be reabsorbed up until the tubular maximum Tm. If the amount of glucose filtered per minute exceeds the Tm amount is reabsorbed for Tm worth, and the rest stays in the filtrate to be excreted into the urine. The renal threshold is the plasma concentration at which TM is reached and the glucose first starts appearing in the urine. So this is just a representation of what I explained in the previous slide. This is just a graph of what I explained in the previous slides. So now I will be discussing the scholarly article. So the scholarly article I will be discussing is the elevation of renal threshold for glucose is associated with insulin resistance and higher glycated hemoglobin levels. So a study was conducted on identifying the factors that determines high renal threshold for glucose. In this study, there were the patients of this study had type 2 diabetes mellitus. And of the study, it was a total of 139 participants in this study, but of the 139 participants, there were only 67 participants that qualified for the study. So 67 participants with type 2 diabetes was used for this study. Okay, so scholarly article continued. So glucose infusion rate is a measure of how quickly the patient receives carbohydrates, and glycosylated hemoglobin to which glucose is bound. For people with diabetes, the normal rate of hemoglobin A1C level is between 4% and 5.6%. Hemoglobin A1C levels between 5.7% and 6.4% mean you have prediabetes and higher chances of getting diabetes. Levels of 6.5 or higher mean that you have diabetes. So the ERTG was determined by using a urine analysis that was collected from the participants. In conclusion, high estimated renal threshold of glucose was associated with low glucose infusion rate, GIR, known as glucose infusion rate, as I previously explained, and high glycosylated hemoglobin, with GIR making a significant contribution. And this is a table that I was able to find in the scholarly article. This is table 3, and table 3 is the relationship of the estimated renal threshold for glucose of variables in participants with type 2 diabetes mellitus, and this is a linear regression. So this is a simple linear regression analysis of the relationship between ERTG, which is the estimated renal threshold for glucose, and other parameters including GIR, glucose infusion rate. As shown in this table, ERTG significantly negatively correlated with GIR and body to muscle fat ratio, and positively correlated with HbA1c and prevalence of insulin use. There were weak and non-significant relationships of ERTG with dyslipidemia and hypertension, and dyslipidemia is abnormally elevated cholesterol or fats known as lipids, and hypertension is also called high blood pressure, and this is when the force of the blood against the artery wall is too high. And these are my references.